Hello, it's Dr. Halim Jaffer. I'm periodontist and I'm about to present a series of lectures on dental science, starting with periodontology. Before we start, I would like to ask you to subscribe to my channel HL Talent to get more videos on this subject. My topic today is about the new classification of periodontology. Scientists needed 20 years to change this classification, which is the last one held in 1999, and since then it's never changed. It was the same classification. But in these lectures, I'll try to explain the details of the new classification of periodontology. So, we're starting from here with these bunch of guys. These are who participated in the changes that happened in the new classification, including members of American Academy of Periodontology and European Federation of Periodontology and other associations and federations. So I was honored to be there as an attendance in this large workshop which is held in Amsterdam Rai in 2018. So this is me at the entrance gate of the Perio 9, which is held at June 20 to 23, 2018. So let us go into the lesson profile. My lesson profile is regarding the introduction, main subjects, and the objectives. The American Academy of Periodontology has published the official proceeding from 2017 World Workshop on the classification of periodontal and peri-implant disease and conditions. This proceeding provided a comprehensive update to the previous disease classification, which is established at 1999. So, this as an introduction of the new classification, and as a reminder, the complete suite of review papers and consensus reports from the workshop, which was co-presented by the European Federation of Periodontology, is available in the June 28, 2018 print and online issue of the Journal of Periodontology. You can take it free, and it's about 21 to 22 research actually. The updated proceedings align with what scientific literature has revealed about disease progression in the last 20 years. As an objective, I'd like to introduce you to a new terms: understanding health, which wasn't present in the previous classification, and going through staging and grading flowcharts, which wasn't present at the previous classification, and peri-implant health and condition in another meaning. Classification includes health and gingivitis case, periodontitis, peri-implant health, mucositis, and peri-implantitis. And after that, I'll show you how to assess a case of periodontal disease. Let us start with the main changes. First of all, we have recategorization of periodontitis. Previously, in 1999, it was, for example, the periodontitis, it was 4 categories. Periodontitis as a manifestation of systemic disease, necrotizing periodontitis, aggressive periodontitis, and chronic periodontitis. But here today it's changed. It became 3 categories. and I'll tell you about that. Previously, we said that, for example, this case is severe periodontitis, severe chronic periodontitis, but now it's changed to stage. So stage is synonym to the severity here. The mild severity is equal to stage 1 when there is less than 50% of bone loss, while moderate is stage 2 when there's the bone loss is at the coronal third, while severe is stage 3, which the bone loss reached the mid-third of the root, while very severe, or stage 4, the bone loss may reach the apical third in these cases. And we have grades. The grade is equal to the rate of progression of the disease, how fast this disease is growing, how fast is the progression of that disease. So we have grade A, slow, and B, normal, and C, rapid, and I'll talk about these staging and grading later. We have definition of gingival health, which is not present in the previous one. So this is an important topic which came into classification. As I told you, during recategorization, the chronic and aggressive periodontitis became titled under one title, which is periodontitis. Simply periodontitis. There is no more aggressive periodontitis. There is no more chronic periodontitis. It is just a periodontitis case. The term biological width replaced with the supracrystal tissues. Trauma from occlusion replaced by excessive occlusal force, because not all the occlusal force is traumatic. So excessive occlusal force is traumatic. The term biotype replaced by phenotype. Bleeding on probing became the main determinant of gingivitis case. Previously, we depended on many factors. For example, gingival swelling, redness, as well as the bleeding, for example, and the red glaze surface or depithelialization of the surface of the gingiva. But today, the main determinant of defining gingivitis is bleeding on probing. Dental plaque changed to dental biofilm. These are the main change in the term and in the concept of the classification. So, let us come into the Euro-Perio 9. What happened there during changing the classification? As a classification, we have this chart. We have here periodontal health, gingival disease and conditions, which includes periodontal health and gingival health. This is a new entity. Gingivitis or dental biofilm-induced gingivitis and non-dental biofilm-induced gingivitis. While in case of periodontitis, previously was necrotizing periodontal disease, chronic periodontitis, aggressive periodontitis, then periodontitis as manifestation of systemic disease. Nowadays, these two remain the same, while aggressive and chronic became a one topic. And we have other conditions that affecting the periodontium, which we talk about it later in separate entities. Because we are talking about the gingivitis, mainly health and periodontitis, and peri-implant disease and conditions, which we have peri-implant health, also new, peri-implant mucositis. This is equal to gingivitis in tooth, peri-implantitis. This is equal to periodontitis in the tooth, and in peri-implant soft and hard tissue deficiencies. So all of the references are 2018 and it is newly updated. So, before everything, we must know the pathogenesis of the disease. Before to know the health, we should know how the health become a disease. As you know that there's a balance between the attacking antigens and the normal body immune response, and this condition called symbiosis, when you have an equilibrium between the biofilm and the immune response. So you have a balance, and this case called a clinical health. The body can resolve the inflammation by itself. But while in gingivitis, when for example the gingiva will be infiltrated by T lymphocytes and B lymphocytes, and more virulent factor will be built up, there will be a defect in that equilibrium, and you have a high biomass of bacteria. So in this case, you may have a disease, but you may get well after taking into consideration the clinical parameters needed for resolving the inflammation. Well, in case periodontitis, which is the cause of the main cause factor is plaque as well as gingivitis, but periodontitis is a multifactorial disease. It's not just caused by bacteria. There is genetic risk factor, there is epigenetic events, there is environmental risk factor, there is behavioral risk factor which affect the periodontitis progression. So in this case, more powerful antigens, bacteria are present, with most of the bacteria becoming gram-negative with high biomass of bacteria. The body will fail to make an equilibrium between the immune response and the type and mass of bacteria. So the inflammation will persist, and the body will initiate to secrete the matrix metalloproteinase and prostaglandin. In these cases, matrix metalloproteinase will enhance the destruction of the connective tissue, and prostaglandin will destruct the alveolar bone as well as the bacteria. So in this case, the destruction will be huge, and once the case reaches periodontitis, it remains periodontitis for the rest of your life because it is a chronic disease, unfortunately. Let us talk about a new entity, which is a definition of health. We know that health is a state of completely physical, mental, and social well-being. And it's not just an absence of disease or infirmity. For example, if you have an absence of disease, but socially and you have a behavioral change. For example, you are a smoker, you are an alcohol consumption person. So you may have a progression factor, predisposing factor, which may lead in the future to the disease. So it's not healthy. You should be mentally healthy, not having stress, which affect the periodontal disease. Physically healthy, you should brush, you should floss. These things are needed to be a healthy patient, a healthy person. It's not just, oh, that person, there is no clinical signs of disease present. When I see the oral cavity, oh, this is a pink gingiva. No, you should have an aggregation of these factors: physical, mental, and social well-being. So periodontal health should be defined as a state free from inflammatory periodontal disease that allows an individual to function normally and avoid physical or mental consequences due to current or past disease. So you shouldn't have an inflammatory process, you shouldn't have bleeding, for example, on probing, and you should function well, you should have a good occlusion, the teeth are present, the caries are filled, the fractured teeth are restored, the absent teeth should be implanted or there's a construction of a prosthesis. So you should avoid physical or mental consequences due to current or past disease. You shouldn't say that I brushed previously but I didn't get benefit from it. You should go on the instruction that the specialist will give you, and you shouldn't use the past mental activity that you have on the past disease and affected you on your life. For example, you have had a mobile teeth previously and you brushed as well, and nowadays you may think that oh, the brushing is have no benefits, why I brush, why I do this, why I do that. No, this is, you should change all of your status to become a healthy person. We have 4 levels of periodontal health. We have pristine periodontal health, which is totally clear. The patient have nothing physically, mentally, socially, and there is no inflammatory process. While clinical periodontal health, we have minimal clinical inflammation with normal periodontal support, with normal bone, periodontal ligament, with normal gingiva, for example. Periodontal disease stability, we have minimal clinical inflammation, plus optimal therapeutic response, plus modifying risk controls. And we will talk about the modifying factor and predisposing factor. So here, the patient is under control, you have minimal inflammation, and both the inflammatory process is controlled with the modifying and predisposing factors. Periodontal disease remission, there is significant decrease of clinical inflammation and stabilization of disease progress. This mostly talk about gingivitis and this mostly about previously present periodontitis, but now it is controlled. What does clinical health look like? Case versus site. What we mean by case versus site? Is clinical inflammation compatible with health? Yes. Can there be a site of inflammation that's also a case of clinical health? Yes. How? For example, if we have a bleeding, we are just, for example, doing bleeding and probing examination of all of the surfaces. If less than 10%, we have a bleeding of less than 10% throughout all the dentition. So in this case, we have in this less than 10%, we have a site of inflammation. But as a case, as a whole, it's a healthy condition. You have sites of inflammation, yeah, but the case is healthy. You have a pink gingiva, you have no swelling, you have sharp edge papilla. The rest of the gingiva, there is no bleeding. So you can cope between the site of inflammation with the clinical health. Periodontal health is defined as an absence of clinically detectable inflammation. There is a biological level of immune surveillance consistent with the clinical gingival health and homeostasis, as we talked about. Clinical health can be restored following treatment of gingivitis and periodontitis, clinical health. The periodontitis can't become a healthy periodontal condition, but clinically could be healthy. How? I'll talk about it later. A case of clinical health represents a different situation to a site of clinical inflammation. How? We said that we may have a site of inflammation, and the other sites, which are the clinical health, which we name it clinical health, are sites of clinical health. So we have sites of inflammation and sites of clinical health. And could be present in the same mouth? Yes. We have some questions here to explain. What's biofilm-induced gingivitis on an intact and on reduced periodontium, and define a reduced periodontium, which is previous periodontitis versus non-periodontitis patient. What are the predisposing factor? What are the modifying factor? Predisposing is local plaque accumulating factor, while modifying factor is systemic risk factor. Can we reduce the number of categories? We will talk about clinical gingival health on intact periodontium. An intact periodontium refers to an absence of detectable attachment and or bone loss. When we say that we have an intact periodontium or a clinical or a healthy periodontium, it means that we don't have an attachment loss and we don't have a bone loss. But clinical gingival health on a reduced periodontium, as we talked about, and I'll make it more obvious for a few seconds, we have stable periodontitis patient. What is stable periodontitis patient? We have normal gingiva and the bleeding within the scope, and the patient was periodontitis. We have recession, maybe we have bone loss, but we have clinically normal clinical features, which I will talk about a few seconds later. And we have non-periodontitis patient, for example, a case of recession due to trauma or crown lengthening surgery, or patients like that. So here I can make it obvious for you. In patient with periodontal health, we name it periodontal health, even if we have bleeding on probing of less than 10%. It's still healthy. And we shouldn't have a pocket more than 4 millimeter. It should be 4 or less than 4 millimeter. And it's mandatory in the periodontal health, that there's no bleeding on probing at 4 millimeter pocket. If we have a 4 millimeter, there should be no bleeding on probing. Well, in case of gingivitis, okay, we have periodontitis patient in case of remission. For example, we have, this is healthy periodontal health in a periodontitis patient. Let's say on the reduced periodontium. If we see a case which has attachment loss and a pocket 4 or less than 4 and less than 10 millimeter, 10% bleeding on probing. So this case is considered healthy periodontium or periodontal health on reduced periodontium, which was previously periodontitis case. Now it is stable. But in case of gingivitis, when we say that, this case is gingivitis on reduced periodontium, on previously existing periodontitis. When we have bleeding on probing more than 10%, and the pockets still should be 4 or less than 4, and still there shouldn't be bleeding on probing at the 4 millimeter sites. While in case of established or unstable or uncontrolled periodontitis, we should have a pocket depth of more than 5 millimeter, and in these pockets we should have a bleeding on probing. So we have periodontal health on reduced periodontium, we have gingivitis on reduced periodontium, and we have unstable periodontitis. As we talked about, once a periodontitis patient, always a periodontitis patient. But such a patient can be a case of health, as we talked about. If we have less than 10% bleeding, and if we have a 4 millimeter or less than 4 millimeter pocket, and if you don't have a bleeding on probing on the 4 millimeter pocket. That's how we can get a health case which was previously periodontitis. When you see this case, it's normal, it's healthy. There's a pink color gingiva, the pocket depth is 4 or less than 4 millimeter, and there is no bleeding on the pocket sides. So it's closed pocket. It's in a remission case. It's in a healthy state. Okay. The only thing that changes the healthy and gingivitis is that if you have a bleeding of less than 10%, it's a healthy. Periodontal health on reduced periodontium. But if you have more than 10% bleeding, so you have gingivitis on reduced periodontium. That's it. These cases are healthy. There is attachment loss, there is bone loss, but you have no bleeding on probing or bleeding on less than 10% of the sepsis, and there is a pocket of 4 or less millimeters, and there is no bleeding on probing on the pocket site. In case of plug-induced gingival condition, we have a question. Is this a case of clinical health with signs of gingival inflammation, or is it a case of gingivitis? We name a case of gingivitis, we name a patient a case of gingivitis when they have more than 10% of bleeding on probing. But if we have less than 10% of that, the case is remain healthy with signs of inflammation. The local predisposing factors, which are the plug retentive factors, include tooth anatomy, restoration margins, overhangs, salivary dryness, increased salivary flow, increased quality of saliva, become more sticky, for example, in Sjogren's syndrome, while taking medication, mouth breathers, systemic risk factors, including smoking, diabetic, nutrition deficiency like vitamin C, pharmacological agents. Some drugs may affect the periodontium, like we talked about previously, phenytoin, cyclosporine, nifedipine, or cause gingival swelling, for example. Increasing sex steroids, estrogen and progesterone during puberty and pregnancy, and hematological conditions. So till now, this is the end of this part of this lecture. I don't want to make it long for you because we have many entities and many subjects to be discussed. For now I stop. I hope you enjoy it and have a nice day, and don't miss that, to subscribe to my channel, please, to get more videos. Thank you.